sure that it works. Oh, wait. Oh, that's it. All right, you can see, you all can see that now?
Yeah.
Okay.
Yes.
Good.
Here.
All right, we're good. I spend my whole day sitting in front of a computer now. I'm getting tired of it.
Yeah.
Honestly.
Well,
They're telling us to stay home, but it's very boring actually. But if I go into work, unless I'm in the place where the patients are being cared for, there's nothing going on. They've suspended all research at our place, except COVID research.
Yeah, but you're doing clinical. You're doing also clinical work.
Yes, of course. But when I'm not on service, I'm supposed to stay home.
Okay. Okay.
So.
I think we'll start. And Bismillah ar-Rahman ar-Rahim. Welcome everyone to our webinar number 31. We started after Eid. This webinar is a part from our educational campaign. It's called Imtinan, and to face the COVID pandemics to our healthcare worker in Saudi. And first of all, I would like really appreciate in behalf of the Saudi Commission, Dr. John Chris from Chicago, from state to attend with us, and Dr. Joseph Foti from the Milan, and Dr. Yassin Arabi. And I'm going to let Dr. Yassin Arabi talk about the title of the webinar and to introduce our speakers. Bismillah. Tfadal, Dr. Yassin. If you would like to unmute Dr. Yassin first.
Thank you very much, Dr. Sami Sulami, for arranging and organizing this webinar. It's a remarkable amount of work you've been doing to put this together, so really appreciate your effort. Dr. Sami and I and the Critical Care Committee has been involved in national efforts to look at the issues related to management of COVID-19. And part of this is the soon implementation of helmet for critically ill, helmet non-invasive ventilation or CPAP for patients with COVID-19. We believe the critical care group feel that strongly that this will be a very useful tool for our patients and maybe help clinical outcomes, but also help saving resources and reducing the need for long stay in the ICU. The objective of this webinar is really to discuss the evidence behind it and then talk about the some of the aspects of how it works, the clinical application, and some of the practical aspects of managing patients on helmet CPAP or non-invasive ventilation. I would like to take this opportunity to thank our two speakers today. We're really privileged to have world-known speakers. My colleague, Dr. John Kress, who is Professor of Pulmonary and Critical Care Medicine and Director of Medical Intensive Care Unit at the University of Chicago, USA. He has a long experience with the helmet. He will discuss with us the randomized control trial that was done on helmet non-invasive ventilation, which really showed convincing results. Interestingly, he presented this in Riyadh a few years ago. He presented to our group at the time was released in JAMA. So it was really interesting. Also, I'm really pleased to have with us Professor Giuseppe Foti from University of Milan Bicocca in Italy. Our colleagues in Italy have extensively used the helmet CPAP during the COVID outbreak. And I think there are a lot of lessons we can learn and they can teach us on how to utilize them properly. So without further ado, I would like to invite Dr. John Kress to start his presentation. You need to unmute your microphone.
There we go. So thank you very much to Dr. Arabi and also Dr. Al-Salami for inviting me to come to speak to you. Dr. Foti and I are going to present one after the other some of the evidence to support the use of helmet non-invasive ventilation for acute hypoxemic respiratory failure. And what I'll do is I'll start with what the idea behind this interface. I should start by saying there are several different devices that are available. I'm not going to speak on the various devices. They all have their own nuances, but rather speak on the concept behind this mode of non-invasive ventilation. It is an alternate interface for non-invasive ventilation, and it has many benefits. Of course, it allows the patient to be able to see his or her surroundings because it's transparent without having anything on the face. And so therefore, problems with different facial contours, with teeth, dentures, things of that sort become a non-issue since the seal is a seal around the neck. And that, as I say, can usually lead to patients not requiring sedation. Or if sedation is needed, typically very minimal amounts to tolerate the device in the throes of the respiratory distress that an individual patient may be suffering from. I'll take this moment just as a sidebar comment to speak on my experience with COVID patients. I am finding that minimal amounts of sedative, typically with a drug like dexmedetomidine, seem more often necessary. And I think that has to do probably with the nature of the lung injury and dysfunction. But nonetheless, the patients can remain relatively awake and interactive when managed with non-invasive ventilation via helmet. Now, there are two different ways that one can use this device. A continuous positive airway pressure, which is what Dr. Foti is going to talk about in more detail, or a inspiratory pressure when hooked up to some positive pressure ventilation machine, a ventilator. But regardless, one of the features of helmet ventilation that has some data to support it is that when patients are on helmet ventilation, their tidal volumes will not be constant, but will vary. And others have used the term noisy ventilation, and there are some animal data suggesting that this type of ventilation may actually be beneficial with regard to attenuation of lung injury. So varying tidal volumes has some animal literature to support it as beneficial. We published a paper in 2016 where patients were randomly selected to get face mask or helmet ventilation. These are people that were starting off with acute hypoxemic respiratory failure, ARDS, and they were then randomized after no more than 6 hours of non-invasive ventilation with a face mask to continue the face mask or to be switched over to the helmet. And as you can see here, the patients who received helmet ventilation had a significant improvement in survival out to 90 days. When we dig into what might be driving that, what you can see here are a couple of interesting findings. The first is that in the helmet group, the PEEP on average was higher. And an important message here, most patients on face mask got an average of 5 of PEEP, whereas on helmet it was 8. This was an area under the curve calculation. And many of our patients in the early phase of helmet ventilation were able to tolerate PEEPs that were above 10. I think the highest PEEP we ever had was 19. And that's very difficult to do with a face mask because of leak. So the average was 8, but the maximum PEEP, which may be the intervention in a recruitable lung scenario that can avoid the need for endotracheal intubation, is much higher with helmet. You can see that the pressure support was a bit higher with the face mask than the helmet, and I think Dr. Foti is going to talk about how the pressure support with a helmet is probably closer to just continuous positive pressure, but I'll let him speak to that. You can also see that the FiO2 requirements were lower on average because I think the PEEP that was tolerable was higher with similar gas exchange by pulse oximetry. What you can see here is that the face mask patients at baseline and then after randomization were tachypnic and remained so, whereas the helmet patients on average had a drop of about 4 breaths per minute in their respiratory rates. As I mentioned, there was a survival benefit. The primary outcome was the need for endotracheal intubation. And you can see here that in the face mask group, as other papers had previously shown, about 60% of face mask ARDS patients required intubation, whereas in the helmet, it was only 18%. And that translated into shorter length of stay in the intensive care unit and better ventilator-free days. The adverse effects were small in both groups and not significantly different. Now, one of the things that I'm starting to notice with the COVID patients that I'm taking care of now is that if they are able to survive, the journey to recovery back to normal is very difficult. And these patients who require intubation often require deep sedation and neuromuscular blockade. So to be able to avoid intubation could potentially offer a benefit. And what we did in our original trial looked a year later in the survivors. And what we found was that the patients who were randomized to Helmet, while at baseline similar characteristics, were able to be mobilized more effectively, that is with physical and occupational therapists, that translated into a significant reduction in ICU acquired weakness and maintenance of functional dependence in the Helmet group, presumably because they were able to stay interactive, get out of bed, move around a bit more. And we're seeing the same thing in some of our Helmet patients with COVID. Rather than laying in bed, intubated and paralyzed, you can sit in a chair and actually get up and move around with physical therapists. This also translated into a significant reduction in delirium and a significantly better likelihood of having a normal CAM ICU, both in the intensive care unit and also throughout their hospital stay. Because they weren't intubated, they received less propofol. That's not surprising because there was a difference in the intubation rate, but the other sedatives were not substantively different. We use a lot of dexmedetomidine, and our second drug of choice for sedatives in our ICU is propofol. We don't use much in the way of midazolam. Lastly, their discharge disposition. When they left the hospital, where did they go? You can see here that the group that got Helmet were much more likely to go home as opposed to some other place and much less likely to die. And that's shown here at the 1 year follow-up. So at 1 year, the mortality benefit was still present. Functional independence was better, and avoiding institutionalization at rehabilitation hospitals and long-term care types of facilities significantly better in terms of the number of days that people that were randomized to Helmet required this kind of care. And there's the 1 year survival Kaplan-Meier curve. Now, that's our paper, but there are other studies that have also looked at Helmet, and here's a meta-analysis by Liu and colleagues that was published in 2016. And what you can see is with several studies, randomized and case control, the overall message is that hospital mortality is improved with Helmet ventilation compared to an alternative. Likewise, the need for endotracheal intubation in case control trials and randomized trials that are listed here is significantly better. That is less endotracheal intubation. Now the numbers here, 285 and 211 respectively, are not enormous numbers, but certainly the preponderance of published data suggests that this device may be useful for the management of patients with respiratory failure, in particular, the COVID type of respiratory failure, which is typically an acute hypoxemic respiratory failure. Although I'll just pause and say, as I'm sure you all are well aware of, the COVID phenotypes, while a good percentage of them are traditional ARDS with airspace filling and gas exchange disturbances and PEEP responsiveness, there is this puzzling group of patients who seem to have very good lung compliance and an inordinately high minute ventilation, suggesting a dead space problem. And I'll let Dr. Giuseppe Foti talk a little bit more about that. Lastly, the healthcare workers. So at our institution, there's been a tremendous amount of worry about the risk of healthcare workers being exposed to people that have COVID-19 because it's such a contagious virus. Here's a nice paper by Hugh and colleagues where they simply put a helmet, these are in mannequins, but they looked at the aerosolization of the gas in a colored green gas here, and you can see that the helmet, all of the gas stays inside the helmet. And so when you have a viral filter on the expiratory limb, you can reliably minimize the risk of exposure of the virus, aerosolized virus, to the healthcare worker. Now, of course, if the neck ring leaks, then some aerosol virus can get out, but the overall amount seems to be substantially less than if you're using face mask non-invasive ventilation, where of course the particles come out the expiratory port. There are ways to get around this with viral filters on the expiratory port, but that's a tricky setup for your respiratory therapy colleagues. So given the concern that many institutions have with regard to exposure, this device, this helmet, may be an alternative not only to avoid intubation, but to maintain safety for the care providers who are dealing with these patients. There are many centers where face mask ventilation is currently just forbidden because of the concern about aerosolization of virus. Now, some hospitals aren't that rigid, but there are those that are, and likewise with high flow nasal cannula. So depending on the place you work at and the policy of the hospital, if I talk to people in the United States, there are many places that simply won't use non-invasive ventilation with a face mask at all because the worry about healthcare exposure, which means if you cannot maintain acceptable gas exchange with low flow oxygen, not pressurized, then you get intubated. So there's a lot of intubated patients that we're seeing at some hospitals because of these concerns about healthcare worker exposure. So in summary, this helmet device provides an effective option for oxygenation in acute hypoxemic respiratory failure without compromising the safety of the care providers. The data that it prevents intubation and death are certainly compelling, and it may mitigate the over-reliance on endotracheal intubation because it offers an alternative for some patients who have acute hypoxemic respiratory failure due to COVID. I'm going to stop there, and I'm just going to say one more time, for some patients, and I'm sure Dr. Foti will talk about his experience with the use of the device and the success rate, which is good, although certainly not perfect. So I'm going to stop there. Thanks for your attention, and I will let Dr. Foti take over.
Thank you very much, Dr. Kress. We'll move on to the presentation by Dr. Foti.
Hello, you see me? Let's try to you cannot start while other. Maybe we should stop sharing the screen because I can't do it. Okay. Okay, let's see if it works. Okay. No. All right. Hello to everybody, and thanks a lot for this opportunity to talk about helmet CPAP. And I will provide you also some technicalities because I think they are important, even because the way that I'm gonna show you to use the helmet is, in my country, Italy, very, very popular since many years, but I do know that is not as much as popular as in Italy in the other places. So first of all, we use CPAP, so no pressure support, just PIP. Very shortly, the evidence, Dr. Kress already discussed about that. I want to show you this small meta-analysis, but it concentrates on the use of helmet CPAP in hypoxemic acute respiratory failure, especially those are all pneumonia patients. So they somehow are very close to the issue that we are going to discuss today, that is obviously COVID-19. And well, I didn't tell you that unfortunately Milano is in Lombardia, and you know very well that Lombardy unfortunately was the first of the Western world stricken place. We had a lot, really a lot, patient with the COVID. Thanks God is going away, it looks like, but was really a mess. Let me say February, March, and April, they were a disaster. It's a very simple system. Very simple. It's a plastic bag, as you say, with the gas inlet. So this is not a ventilator. It's just a free flow source of gases. And here is connected to a PIP valve. Very, very simple. Then you pressurize all the system, and you have a very good CPAP with a very good pneumatic. Let me tell you, I was born actually with a helmet CPAP when I was, now I'm 60, but when I was a fellow, so before I was 30, in my 20s, somehow, it was the first system that I used, that they teach me. My first boss was Luciano Gattinoni, and this was the first system that, and maybe the only system of CPAP that I've used. So I want to concentrate on a first technicality. Since the patient is breathing inside in a plastic bag, it's mandatory that inside this plastic bag there is a fresh flow gas in order to wash out the CO2. That's very important. This study was done, as you see, many years ago, almost 20, and was done on healthy volunteers. Actually, we were the volunteers. And this is the bias flow inside the helmet. Bias flow means the fresh flow of gases going inside the helmet, going from 20 liters per minute to 50 liters per minute. As you can see, CO2 inside the helmet, this is not the CO2 of the patient, this is the CO2 inside the helmet, goes up if you decrease the bias flow inside in the helmet. And when you go at 20 liters per minute, you have an unacceptable high level of CO2 inside the helmet, some 10 millimeters of mercury. This is a lot of rebreathing. That's not good. Since we are healthy volunteers, we just increased a bit our tidal volume. Actually, we did not feel a lot of dyspnea, but certainly some discomfort. So my first technical issue that is very important to remind, it's to use a bias flow, a fresh flow of gases inside the helmet, at least of 50 liters per minute. Then we're gonna see how to do it. Simple, but keep it in mind. I want to share with you some data that are not published yet, but are experience of the last 2 months, just to give you an idea. And I wanted to share with you just the experience in my hospital. It is one of the hospitals of Lombardia. And we had to deal with more than 1,000 COVID patients requiring oxygen inside the hospital. My hospital is 620 beds, just to give an idea of the situation. Almost 400 patients in 2 months were treated with the Helmet CPAP. I'm talking about patients treated outside the ICU. All the patients going inside the ICU, they have to be intubated. No, because we didn't have possibility to treat patients on non-invasive ventilation in the ICU. Too many patients and shortage of bed. I started with 25 beds ICU, and I end up after shortly to almost 100 beds, but they were not enough anyway. So in this patient, the indication to use the CPAP was mild hypoxemia below 93 of saturation with dyspnea, breathing with a bag mask of oxygen. So this was the indication. And we reached a peak of 120 patients simultaneously in CPAP outside the ICU, just to have an idea. And I'm going to show you the preliminary analysis on a sample of 230 patients out of those 400. Okay. You have this is something that you see always very easily when you apply the Helmet CPAP, the increase in on saturation and PF ratio. Remember, the FiO2 inside in the helmet is certain. You can measure it precisely. Maybe the FiO2 of the oxygen mask instead is not precise. We attributed to the non-rebreathing oxygen mask an FiO2 arbitrarily of 0.6. So just to have an idea of what we're talking about. Anyway, PF ratio increased very much. This is very normal when you use Helmet CPAP. Then there is the effect is due to PIP and also maybe a better control of the FiO2. So this is we had a patient, unfortunately, maybe this is, you know, in Italy, DNI do not intubate code is not very common. It is not, I'm sure in somehow, I think we are more close to Saudi Arabia than US. That's my guess as a population, okay? Anyway, so keep it in mind, but we had to do it. We had to do it, and we had to establish a do not intubate code because frailty and age of patient. So the patient that we decide do not to intubate, the failure of the system was high, unfortunately, and we have only a survival rate of 20% of this patient. They were obviously older and frail. Let's see in my opinion, the good part. Those are full code patient that had an indication to go in ICU if they need it. But we started to treat them outside the ICU with the helmet. As you can see, approximately the success rate of the Helmet CPAP was approximately 80%. The blue bar, see, the success rate, and the green bar, the failure rate. You see the number here, approximately 80% success. The patient that succeeded helmet CPAP, they survive, all of them. The patients that were intubated because they did not succeed, the helmet CPAP, and we had to transfer them on the ICU, they had a survival rate instead of 76%. I should add something in order to understand what we did during the COVID. So also we started to apply something that we just published a few years ago, but we didn't use in clinical practice very often. And instead, in this case, we used extensively. That is pronation in spontaneous breathing. So somehow we were telling to the patient, please turn around. And we did much more than 50 patients, but we could study in a scientific way 50 patients. The paper is under review, is an advanced phase of review. Anyway, I think is fair to show you the data at this point. We studied 50 patients. The vast majority was on CPAP, but also we had a 10 patient that was just in oxygen. They were with the helmet and in prone position. The helmet was not feasible in this patient in 10% of them. And actually, so the patient were slightly more than 50. 50 are just the one. There were 50 patients, and some of them instead they couldn't be kept pronated because we decided that at least they should stay prone for 1 hour, at least. The mean duration of pronation was 3.5 hours, and those are the results in terms of PF ratio that increased dramatically in all of them. And then in some patients, you got a long-lasting effect, and in some other, as soon as you put the patient back on supine position, they go back to the previous PF ratio. I wanted just to stress the point that you can combine, and we did combine helmet CPAP and prone position. Obviously, I cannot tell you, it's not a randomized study. I cannot tell you if it makes a better survival. It just improves dyspnea and PF ratio. That I can tell you. So let's go a bit more into the technical detail. I told you already about the flow, the importance of flow, at least 50 liters, maybe a bit more. Then there is the issue of noise inside of humidity and the fixation of the helmet. This is something maybe is new for you. I understand. You have two systems to drive the helmet. The normal system that we have in the ICU, oxygen and compressed air. You decide the flow of oxygen and the flow of air. Okay? And then this is the system that we use outside the ICU. It's a Venturi system. You see, the white line is the connection to the oxygen of the ward. And then the line A is the one that you turn the knob, you increase the flow goes inside to the Venturi. This is the Venturi, and the Venturi is getting air from the ambient. Very convenient, very convenient. You can get a lot of flow in this way, a lot of flow. Usually a Venturi such this one, for one part of oxygen, you drive 4-5 parts of air. So you have a mixture with an FiO2 around 30-35% here. If you want to increase the FiO2 because the patient is hypoxemic, then you have to add some oxygen also on the second line here. See the blue, the little blue tube? So downstream, the Venturi effect, you put some oxygen to increase the FiO2. Okay, this picture, this is simulation. No, it's not. It's done with the mannequin and expiring CO2, and I wanted to stress the concept of the flow inside the helmet. Here, the flow inside the helmet is 20 liters per minute. The blue is the CO2, and see the CO2 accumulate inside in the helmet because there is no enough flow, rebreathing. Now we go to 90 liters per minute. That can be easily achieved with the Venturi system, easily. See, expire the patient, but the high flow clear up the CO2 quickly, see? It disappears. That's important in order to avoid rebreathing, and so additional effort for the patient. This is once again the system, the line A, the Venturi, room air. The flow goes to the patient here, and you can add with the second line some extra oxygen. Then you can measure with the O2 analyzer the FiO2. In this case was just room air. In this case was almost 100% of oxygen. Very important, the issue. What is happening? Sorry. Sorry. Let's see. But this is okay. Dr. Kress already talked about the problem of healthcare workers, the risk. Helmet is also in CPAP, can be a safe device. You should add a filter on the expiratory port. This is the HEPA filter, and this is the PIP valve. Very important, the HEPA, this filter has two functions. One, to avoid spreading of viruses around. Second, very important, decrease the noise also, because it acts like a muffler. It decreases the noise. That is important, because if you have a high flow, the patient gets a discomfort if it is too noisy. Then there is the problem or the issue of humidification. It is not a marginal issue, especially if you use compressed air. So if you use compressed oxygen, medical oxygen, and medical air, they are super dry, too dry. And if you try to stay inside, I did it myself, after 5 minutes, you realize that something goes wrong. You're coughing, dry. So if you use this system, you must humidify. But you cannot go with the normal humidifier, with the normal standard. Because if you put the temperature at 37 degrees and the humidity 100%, you have a kind of a Calcutta effect. Bombay, super humid, and you got fog inside the helmet and the patient discomfort. So if you use the humidifier, you should adjust the humidifier in order to have the lowest possible temperature. This system is decent, 28 degrees, it's decent. But it's much more easier if you use it with a Venturi system, because room air is already humidified. And so you don't need to add an extra humidity. As long as your FiO2 is below 60%, it means that the amount of oxygen is equal to the amount of air. Then you are pretty sure that the amount of humidity they get, it's enough, and you don't have to get this problem. So my suggestion, especially when you start, use an FiO2 not above 0.6 and use a Venturi system. Venturi system with an FiO2 below 0.6. I'm going to finish. Fixing option. Oh, they tell you, the factory, that you should put this stuff here below here. This is convenient if you stay on CPAP for 2-3 hours. But if you stay 24, 36 hours, and this is possible to stay for such a long period of time, it is better not to put it in this position, but just outside the arm, in order to avoid discomfort venous stasis, okay? Especially in COVID patients that are very prone to coagulation disorders, as we know very well, unfortunately. And finally, this is my last slide. The kit. What do you need? The helmet, actually, this is there are in Italy there are 3 factories making helmet. The tubing, the Venturi system connected to the oxygen source, the measurement of FiO2 that is convenient and easy, the PEEP valve, and the filter for the virus and to decrease the noise. So I finish, and thank you very much for your attention, and I hope there will be some question for me and Dr. Kress.
Thank you very much. This is an outstanding overview. Really appreciate the 2 presentations. Lots of things to learn. So clear messages that helmet can be used either connected to the ventilator, the model described by Dr. John Kress with using press support, or with using CPAP without the ventilator, which can be done on the ward without connecting to the ventilator. Both are really good approaches and something to learn. The advantages is that you don't need sedation. If you need sedation, maybe small dose of Presdex may be able to do it. I think the selection of patients is important, was highlighted by both by Dr. Kress and Dr. Foti, the right patient. It was mentioned that the one big advantage is that you can give high positive pressure. So highlighted that average PEEP of 8, but you can give much higher pressures than this 12 or higher. Early mobility, patient can remain awake. You can manage the patient on the ward. So there are a lot, and you can use prone positioning awake as shown by Dr. Foti. It's very nice. And then you can use your this for the patient who do not intubate, which is another big advantage. I have a lot of questions from the audience, so I'm going to go through some of them. Really good questions. So one question came to mind. How long patient can stay on helmet? Days? How long patients can stay on this? The other issue, how do you manage these patients for example, feeding, expectoration, noise? One of the question was about the eyes. Do patients have any eye problem when you use the helmet? Ear problems also with the pressure. So maybe Dr. Kress, you want to start?
Sure. How long? I would start by saying the first hour or 2 is really vital. If the patient is going to succeed and stay on the helmet, typically in the first hour or 2, you have a good sense of that. And there is a fraction of patients for whom, as Dr. Foti already said, the helmet doesn't work. And failure to recognize that it isn't working is really important, to not let that happen. The duration is quite variable. We've had patients stay on the helmet for 3 or 4 days. Although I would say on average, since often the nature of the problem is being treated typically with diuretics and things of that sort, usually in a day or 2, you're moving in one direction of improvement or another direction, failure, and the need to intubate. That's been my experience, at least. And you asked a bunch of questions about the eyes and the ears and the noise. Maybe I'll let Dr. Foti answer those.
Yeah, well, I think the capability to stay in the helmet for a long period of time, it is probably the real, let me say, magic bullet. There was a study, as I remember, not a large one, but an Italian study on a hematologic patient in which they compare helmet CPAP versus mask CPAP. So the same technique, same principle. But they have an advantage in survival on the helmet CPAP. Why? Because the time that the patient spent on face mask CPAP was on average 7-8 hours. On the helmet, 28. So this is very important. So we know that ARDS patients are different from chronic obstructive pulmonary disease. They can, COPD patient can be ventilated for 4 hours, having a rest, having another run of ventilation. But the ARDS ideally should stay always with the pressure. This is not possible for 1 week, but longer the period, more effective is the treatment. So this, I think, is very important. And this is why I concentrate on technicalities, because technicalities are the one that make possible to stay for a long period of time. So feeding, usually those patients, they have a nasogastric tube because the treatment it takes, it does not last 1 day or 2 days. Certainly, if they do good, at least 5-7 days of not continuously, but so they have to be fed. The problem of the pressure on here, it does not apply to CPAP because it's a stable pressure, so it's not a problem. It could be with a pressure support because you have a fluctuation. Maybe Dr. Kress better than me can talk about it. The problem of the noise is very, very important, the noise. You have to find the balance between high flow means zero rebreathing, but means also some noise. So this is why I suggest you some 50 liters, because it's a good compromise, a very good compromise. Then you use the filter that is a muffler. So it decreases dramatically the noise. You do it, you apply the filter on the Venturi system and you realize immediately the difference in noise. And also remember the arm, because if you stay for 24 hours pushing in the arm, some patients complain of paresthesia on the end and then some swallowing. So it's discomfort. You have to be very good. The respiratory technician has to work a lot, but it is worth doing.
As far as the secretions, depending on the particular patient, some of the helmets actually have a device on the front, which is like a lid of a jar, and you can unscrew it, and then you can go and let the patient spit into a suction catheter. Obviously, when you unscrew it, the helmet deflates, but then when you put it back on, it reinflates rather quickly. Some of the helmets have a smaller little port down here that you can pass a little suction catheter up and suction the patient. If I just simply can't deal with the secretions by those approaches, I may take the helmet off temporarily, let the patient spit into a cup, let the patient rub their eyes a little bit, and then just put it back on. And then as far as the pressure support in the ears, we didn't find that to be a common problem. There are some people who have really bad sinus and ear trouble. And it's like if you go scuba diving. There are some people who have bad ear problems who just simply can't scuba dive. And if they scuba dive, they'll rupture their tympanic membrane. Small percentage of people, but similarly, every once in a while you get somebody who has really bad ear problems and the helmet just won't work because they can't tolerate that pressure in their ears. they're probably the same type of people that always feel bad when they fly in an airplane, would be my sense.
Do you routinely use earplugs for these patients?
No, I don't. I try to, usually I can reduce the noise, as I told you. And I can add also that there is also a type of helmet in Italy that has a zip here. And you understand zip?
Yeah.
Okay. That is very convenient. The zip is, you can open it up, do nursing on the patient, do whatever you want, and then back. This is, I found it also very convenient.
So
I don't use earplugs usually, but I have them ready for an occasional patient who, with the muffler, still complains of the noise. And occasionally it can be useful, but I don't use it routinely.
excellent. Other questions? This device, or this is supposed to be single use. Can this be reused? Is there any experience of reusing them or no?
No, you
No?
know, look, let's say in peacetime, we do not reuse it.
Okay.
In wartime, and it was a wartime because we had a shortage of the helmet in Italy. Even
Yeah.
the factory were doing as all they could, but they could not provide us all the helmet. So the patients were all COVID. So we cleaned them up. But since 7,400 people are listening to me, I don't want to go to jail.
We have actually set up an arrangement with our central supply sterilization team, and they do sterilize them. You can't autoclave them because the temperature will melt the material, but either using hydrogen peroxide or some other type of chemical sterilization, you can do it. And that's what we've done for the same reasons Dr. Foti said, because of just a demand. A demand is this much and a supply is this much. We're just running out.
Okay. Question about one of the problems we face with the face CPAP or non-invasive ventilations is the pressure injuries. Do you see any problems with around the neck with the helmet? Does it happen?
No, there are also helmets now that the only part that could be somehow rigid is the ring, that many helmets now in Italy is completely is soft. So the green one that I showed you in the last slide is a very rigid one, and so we put a pillow on the back of the patient. But usually the other helmets are soft. This is the only point in which you have the cubitus. No problem, minor problem on the neck. Nothing to compare to face mask. Nothing to compare.
Fantastic.
I agree.
Excellent. A question about the use of helmet in pediatric. Any experience with the use in pediatric patients?
Yeah. There are helmets that are provided. How do you call the not napkins? You know, when the baby, you put the underwear, the, how you call it, crest. Give me a hand. The underwear of the babies, anyway, it goes. Maybe I try to find the picture. Anyway, this is for pediatric patient, also very small one, also near a few kilograms. There are a small helmet, even if for CPAP, the dimension of the helmet are not crucial. Actually, if it's a bit larger, it's better because it's a better pneumatic behavior. Anyway, can be used in pediatric patient. And not COVID, thanks God, we didn't have any. We have 2 pediatric patients, but we not without a respiratory failure, but with another problem, cardiomyopathy.
Can the helmet be connected to CPAP machine or non-invasive ventilator?
John, I go ahead, may I?
Yes.
Yeah, I didn't tell you in my presentation, but this is something not important, more. You cannot connect the helmet to a ventilator and put CPAP modality. Don't do it. Because the ventilator has a target to keep the pressure stable. So if the patient is breathing 10 liters per minute, the ventilator will provide 10 liters per minute. But as I told you, 10 liters is a huge rebreathing. So if you use, and Dr. Kress could explain much better than me, the pressure support, you have a washout of CO2 because you give large volume to the helmet. But if you use CPAP, this is very, 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 very important. Please do not connect it to the ventilator in CPAP modality. Please don't do it.
How about BiPAP?
I agree. For the reasons that Dr. Foti said, you need fresh gas flow to wash out CO2. And if you hook someone up to a conventional ventilator, the fresh gas flow through the circuit will not be adequate. The BiPAP, the bi-level pressure, raises the flow of fresh gas into the helmet, thereby washing it out. If you want to know what the actual flow rate is in a ventilator, it's tricky because, of course, with BiPAP, the flow rate of fresh gas into the helmet is variable. If you hook somebody up to a CPAP on the wall oxygen and air delivery system, you know what the fresh gas flow rate is because it's on the dial right there. But if you're on a ventilator, the fresh gas flow into the helmet varies depending on what portion of the respiratory cycle you're in. If you want to, you can look at the flow versus time waveform on the ventilator, and you can look at the area under that curve to estimate it. And if you really wanted to be precise, you could mathematically calculate it. No one does that. But typically with pressure support, the fresh gas flow during inhalation is 150 or more liters per minute. And that's more than adequate to wash the CO2 out, because during exhalation, of course, the fresh gas flow on pressure support is just back to the baseline CPAP.
Excellent. I have a few other questions and we'll conclude with this related to the patient selection. So I have a question whether this can be used in hemodynamically unstable patients. I have a question on whether this patient can be used in patients with some decreased level of consciousness. And there's a question about whether this can be used in non-COVID patients, which is obvious. I mean, this has been used in COVID and non-COVID. But if we can comment on the proper selection, I think it's very important to select the right patients. Otherwise, you'll end up with lots of failures and maybe problems. So what would you suggest for selection?
Well, first of all, the category of patient that would get the most benefit is cardiogenic pulmonary edema. Okay. Mm-hmm. That's obvious, but we ran a few years ago a study, 20 years ago. The use of the helmet inside in the ambulance before to arrive in the hospital in order to control respiratory drive and the hypoxemia. It works very well. But so for the cardiogenic pulmonary edema is perfect, but we know it right now. All the CPAP systems are perfect. In hemodynamic instability, well, applying a PEEP we didn't use it in cardiogenic shock, for example. We have to be careful, like any other kind of positive pressure system in a hemodynamically unstable patient. So no difference. Regarding to the level of consciousness, it is always the same reasoning. You have to be aware of the risk of ingestis, vomiting, but even I understand it is not very nice what I'm going to say, but as you can imagine, is somehow more dangerous vomiting inside in the mask than in the helmet. Maybe it's not pleasant to see, but somehow, forgive me, is less dangerous. But it's true that if the patient needs intubation because the level of consciousness is not okay, helmet CPAP is not the solution. No question. I don't know what John thinks about it.
I agree with everything Dr. Foti said. I will add one thing with regard to hemodynamic instability. Energy expenditure to breathe normally is a very small fraction of total energy expenditure. 1 to 5% of the cardiac output normally goes to the respiratory muscles in health. In patients who have high minute ventilation, high energy expenditure with breathing, the blood flow to the diaphragm and the accessory muscles can go up tenfold, even higher. We call that type 4 respiratory failure. And if so, if the patient is hemodynamically unstable, I would be hesitant. That doesn't mean you can't ever use it. And you have to make some practical decisions. So for me, if you've reached more than one vasoactive drug, I probably would not use it. If you're on a low dose of one vasoactive drug in a patient who's alert and who is not working hard to breathe, you could consider using it. But when I start adding vasoactive drugs, I begin to say to myself, be careful, because this patient can deteriorate very quickly. And if the work of breathing becomes excessive, you exacerbate the shock.
Last question or comment. Do you have any guidelines or protocols that we can share with us so we can develop our protocol for safe use of helmet? If that's possible, this would be really much appreciated.
Well, I could send you the helmet bundle.
Okay.
That the helmet bundle is work done mainly by our nurses that since many years try to concentrate on the best way to do the helmet in order to make it feasible, comfortable, and so efficient. And well, regarding the indication are actually, I don't have a written protocol, and what I say during the presentation is mainly what we do.
Okay. Well, if you can share with the nursing bundle will be very useful when we as we are developing our protocol.
Okay.
Yeah, I think a nursing bundle, we don't have one. I can give you what I have, but it's very minimal, honestly. But having, because as Dr. Foti said, one of the really important aspects that will impact success or failure is attention to detail, finding individuals who have experience and interest in this. You know, as Dr. Foti said a few minutes ago, a respiratory therapist is going to be making a lot of adjustments. So having a good respiratory therapy team who can come and troubleshoot many of these problems that are easy to fix if you just understand the basics. But if you don't understand the basics, a patient can quickly deteriorate for reasons that in hindsight would be fixable. So having champions, nursing and respiratory therapy, I think is really important to enhance your success.
Well, with this, I really thank you. We have, this has been remarkable. There's close to 7,500 attendees
Wow.
of this webinar. across Saudi Arabia. So very exciting. We're gonna post this presentation and the video on the website of the Saudi Commission for Health Specialties. And I like to thank both speakers, Dr. John Kress and Dr. Giuseppe Foti, for their time and valuable contribution. And thank you, Dr. Sami Sulami, for putting this together. And I don't know if you have final words, Dr. Sami.
Thank you so much. Yes, I'm just re-emphasize. Thank you, Saudi Commission, Dr. John, and Dr. Foti. Thank you again. Thank you, Dr. Yassin, and thank you for all people attend, the 7,500 who attend with us. And this is going to be. Thank you so much.
Thank you, Sami.
Thanks.
Thank you all.
Okay.
Bye.
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 Yeah. Thank you very much.